Hello and welcome to the Neuroblastoma Parent Global Symposium. My name is Helen McCarthy-Tennant, and I'm a neuroblastoma parent, and I will be moderating this session on maintenance therapies. We have three presentations today. The first one from Dr. Shakeel Modak, pediatric oncologist and chief of neuroblastoma service at Memorial Sloan Kettering Cancer Center. Dr. Giselle Sholler, the ISF director of the Solid and Rare Tumor Clinic and chair of the Beat Childhood Cancer Research Consortium. She's at Atrium Health Levine Children's Hospital. And lastly, with a pre-recorded piece, we have Dr. Lucas Moreno, pediatric oncologist and division head of pediatric oncology and hematology in Vall d'Hebron Hospital in Barcelona. Before I hand over to our first speaker, I'd like to draw your attention to the panel on the right-hand side of your screen, where you can submit your questions. There's an option to do so anonymously if you choose. We have both Dr. Modak and Dr. Sholler in live today, so both of them can address questions after the presentations have concluded. So for the first one, over to you, Dr. Modak, for your update on the vaccine study.
Hi, can you see my slides?
Yes, you can go ahead. I'm sorry, Dr. Modak. Yep.
You can see my slides, right?
Yep, I can see them.
All right. All right. Thank you so much for inviting me for this very important symposium, and I wish we could all be there in person. It's really one of the highlights of my year to come and meet people. And as many of you know, I trained in England, and I miss the in-person meeting. But nevertheless, I think it's really important that we try to share what we're doing here with parents and get feedback from everyone. So I'll get going. I was asked to talk about the vaccine treatment, and in general, wanted to also put in context maintenance therapies for neuroblastoma. So these are my disclosures. Just to make a point that Y-mAbs, the company that owns the rights to antibodies, it does also own the right to the vaccine, but they are not the sponsors of the study, nor are they providing us the vaccine drug currently. So just to keep this a small point to make. So today I wanted to talk about why should we consider maintenance therapy? What is a cancer vaccine? How do we make a vaccine against neuroblastoma? To present the data from the phase 1 and 2 protocol, which was completed, the new protocol that is underway, and where we see this going in the future. So the first question is, why should we even think about maintenance treatment for patients with neuroblastoma? So the first group of patients where we should look at is patients in first remission. So patients have received chemotherapy, gone into remission, and then receive antibody therapy as consolidation. And this is a slide from our group using mouse 3F8 as maintenance. And as you can see, the progression-free survival at a very long follow-up of 10 years is 60%. Whereas if you look at the same progression-free survival at 3 years, it's something between 70 and 75%, which is what we see currently with either dinutuximab or dinutuximab beta, or with naxitamab, which is 3F8. So between 3 and 10 years, about 15% of our patients are relapsing, even though they were in remission at 3 years. That is, all the scans were clean at 3 years. And so that gives us a rationale for thinking, is there some more treatment that could prevent that fall off? So that's for patients in first remission. That's the rationale for thinking, what else can we do after finishing antibody treatment? But the data I'm going to present today is on patients in second remission. That is, patients who relapsed, then received a bunch of treatment and went back into remission. I hate using Comic Sans here, but I just want to drive home the point that patients who relapse have to get into remission in order for us to consider maintenance in this group. And the second point is that an increasing number of patients are achieving second remission now in the era of chemoimmunotherapy. That is, patients who relapse respond to chemoimmunotherapy at quite a high rate, whereas in the older, before that era, remission was not always possible in patients with relapse. But now about 50% of patients at least would go into remission after relapsing. So this group of patients, 101 patients, they received all sorts of treatment. All of this is in the era before chemoimmunotherapy, and they achieved remission either with local radiation, irinotecan, temozolomide, et cetera. And then when we look at this group of patients, we would consolidate them, that we would give them maintenance treatment with mouse 3F8 and GM-CSF. And you can see the progression-free survival in those 101 patients was about 35 to 40%, and the overall survival was better. So even in the days before vaccine, our standard practice was to achieve remission and then reconsolidate with mouse 3F8 and GM-CSF. So these two observations make us consider using maintenance therapy to maintain remission. Switching gears a bit, what is a cancer vaccine? Cancer vaccine, in simple terms, is any therapy that will elicit an immune response against cancer within the patient. And this immune response should ideally be exclusively against the cancer and should not hurt other organs. Now, a cancer vaccine can elicit two types of responses. One is antibodies. So a vaccine can elicit or make endogenous 3F8 or dinutuximab-like molecules within the patient. And we can measure these in the blood, and we call them titers. So this is easily measurable. But in order for a cancer vaccine to work, or even to make these antibodies within the patient, they also have to stimulate T cells. But T cell function in this setting is not that easy to measure. Now, why do a vaccine when you already have antibody? Because when we use antibody, these antibodies are only working while they're circulating. And typically, antibodies will circulate for 3 to 7 days after you finish the antibody infusion, and then there is no more immunotherapy going on. So the question is, what if we can elicit long-lasting antibodies, perhaps at low levels, which can lead to long-lasting immunity? That's the idea of making a cancer vaccine. There are numerous challenges to cancer vaccines. The development of cancer vaccines went through a phase about 20 or 30 years ago in the adult world, and the results were disappointing. There was only one FDA-approved cancer vaccine for the last several decades, and that was a dendritic cell vaccine for prostate cancer. And about 5 to 6 years ago, another vaccine for melanoma was approved by the FDA, in which a virus which releases GM-CSF is injected into the melanoma itself. So finding the right antigen has been very difficult. Eliciting the response only against the tumor and not against normal tissues has been difficult. Another problem in development of cancer vaccines is people were very ambitious and wanted to have cancer vaccines work when there was a lot of disease. But that is really over-ambitious. Is really not what vaccines are designed for. So it was no surprise that cancer vaccines did not succeed when people tried to use them against high-burden disease. And in children, stimulating an immune response is difficult because many antigens are present even on normal growing tissues. So it's a challenge. What's the challenge specifically for neuroblastoma? In neuroblastoma, the valid target or the most commonly used target is GD2. Now there are 3 approved antibodies against GD2, but our body really doesn't see glycolipids or sugars and fats as part of it. It sees these molecules as part of itself. So making an antibody against sugar and fats, which is what GD2 is very difficult. In fact, when people try to make vaccines against infections like pneumococcus and meningococcus, they found it difficult to make it because these bugs have a lot of lipopolysaccharide or glucose and fats on their cell surface. And they needed to use strong helping substances called adjuvants. So just to keep some of these concepts in mind as I go along. So when we decided to create a neuroblastoma vaccine, it was kind of a serendipitous observation because our colleagues, Phil Livingston and Raghu, were making vaccines against melanoma, and they chose two antigens or two molecules that are also present on neuroblastoma called GD2 and GD3. And then they stabilized these antigens by connecting them to a substance called a lactone, and then they tested various adjuvants. The two adjuvants they had included in their vaccine were KLH and saponin. And KLH is a molecule that comes from shellfish, and saponin is a molecule that comes from a tree bark. So you can imagine that these are very alien substances to the human body, and it's not surprising that the body will mount an immune response against them. Although we don't want the immune response against these, we want an immune response against GD2. But these molecules will stimulate the body to mount a stronger immune response against GD2 and GD3. And then our own observation was that a molecule called beta-glucan can further enhance this immune effect. We also decided to test this vaccine at a time of minimal disease as a preventative measure and not to repeat the mistakes that were done over the last few decades. So as many of you know, we tested this vaccine, which consisted of GD2, GD3, KLH, saponin, and glucan. Initially, we presented a phase 1 trial. In that phase 1 trial, which we used to finalize the dose of the saponin or QS21, we treated 15 patients. All of these patients had relapsed. Some of them had relapsed many times. And we found that we didn't have any adverse events. And this first patient was treated, I think, either in 2009 or 2010. And then we were surprised a few years later to find that 13 of these 15 patients were still alive, and 12 of those 13 had not relapsed, which was against what the dogma or a textbook would tell you, that patients who relapse with neuroblastoma invariably relapse again. So it took us some time, and we didn't really have a sponsor for the study, and to make it was difficult. But when we observed this in about 2012 or 2013, we said that there might be something happening, and so we made a lot of more vaccine, got more beta-glucan, and launched a phase 2 trial. So in this phase 2 trial, which has been published, Dr. Kushner was the PI, principal investigator. This phase 2 trial had basically 2 phases, and the first phase is the one that was published earlier this year. And we asked the first question is, does this vaccine actually elicit an anti-GD2 response? And we had set the bar quite low, and we wanted most of our patients to survive without remission for more than 6 months. So those were the questions in the study design. There were 102 patients. I wanted to point out that only 64 of them were in second remission, and 38 of them had relapsed more than once, and between 2 and 8 relapses before they got to the vaccine. The first thing we saw that the toxicity was very minimal. Apart from injection site reactions and fevers, we really did not see any significant toxicity. So that was reassuring. And then we looked at the survival in our patients, and we found that if we take the whole group of patients, 102 patients, the progression-free survival was about 35%, and the overall survival was about 75%, and with quite a long follow-up. So even at 5 years, you can see that 75% of those patients who came in were alive, although at 5 years, only about 30% had not relapsed. But remember, this is a group which has second and third remissions and fourth, fifth, sixth remission, etc. So if you only look at those patients who are in second remission, you can see that that group of patients is doing better than those who had more than two remissions, more than two relapses before, or more than one relapse before. And again, this group of patients is also is surviving much longer than those patients, which is of course understandable. If you have only one relapse versus two relapse, it's understandable that this group of patients will fare differently. Then we ask the question is, was this phenomenon because of antibody that they had received? Because a standard approach is to use antibody first and then go on to vaccine. We do see that those patients who received antibody relapsed less, but the overall survival was not different, suggesting that the vaccine might be having some long-lasting biological effect. Now, we also asked whether if patients have a longer response to their salvage treatment, did those patients do well or not? And again, those patients who had a better response to their salvage did better, which is also logical. But we did not include patients beyond 12 months after they had achieved remission. So this 12 months here is the time from their relapse. Again, these are kind of expected observations. But what we were very pleasantly surprised, or we found what we had hoped for, is that the vaccine does make the anti-GD2 response we were hoping for. As you can see, when you do the first dose, the GD2 response goes up a bit, and then after 2 doses a bit more, after 4 doses a bit more, and then around dose 5 or dose 6, the anti-GD2 response maximizes. And these are quite high titers. If you look at this, it's almost 1 microgram per ml of antibody, which is quite a lot. And it's nice to see that with this amount of antibody circulating the patient's system, patients still don't experience pain. Now, when our colleagues had tested this vaccine in patients with melanoma, it was not a success. So the company actually, which was making the vaccine, yanked the vaccine from testing, and actually the company folded. But we had some samples from patients with melanoma, and we found that their antibody titers were very, very, very low, much lower than what we were seeing in our patients. And one big difference between melanoma patients and our patients was that we were using glucan. So we hypothesized that beta-glucan might be important in the success of our seeing patients achieve antibody responses. Not only did we see responses, but we found a direct correlation between the titers, that is the amount of antibody circulating, and the progression-free and overall survival. So patients who made an arbitrary cutoff 150 nanograms per ml had a much better progression-free survival and overall survival than patients who made less than 150. But having said that, not every patient who makes less than 150 nanograms per ml relapses. And even these patients, if you look at their survival at 5 years and beyond, a substantial number of patients are still alive at that time point. So we have more to learn, but at least it proves the principle that we're looking for, is that anti-GD2 antibody is what is making the vaccine work. So far, our conclusions were that we could, despite many previous progressions, we could achieve durable remission. And it was patients who had previous more than one relapse did worse than patients who had did better patients who had more than one relapse did worse than patients who had only one relapse. Anti-GD2 response was a predictor of survival. We did not see any pain, and we wanted to study glucan more. And we finished this part of the study in about 3 or 4 years ago, and only after we saw this phenomenon, we thought that we were on to something. So we expanded the patient pool to include those patients in first remission. And so before this point in time, we were only treating patients in second remission with vaccine. So the second part of the trial has also been completed, but we haven't finished our analysis. And the second part of the phase 2 trial was to see if glucan given early would be better if glucan than starting glucan after after dose 3, as we were previously doing. So we randomized patients. Half the patients started glucan after the first dose, and the other half started glucan after the third dose. And we tested their immune responses, survival, etc. And this group included patients in first remission. Now in this part of the trial, which is not published or has not yet even been presented, we have treated more than 200 patients. And what I can say is that in general terms is that the toxicities were similar. Anti-GD2 titers was seen in early and late glucan groups. And there was a suggestion, although that remains to be proven statistically, that anti-GD2 titers were higher in those patients getting early glucan. Again, we still have to crunch our data to make a definitive statement, and other correlative studies with survival and changes in the gut microbiome are still being tested. So at the end of this large phase 2 trial, some questions still remained. One is if indeed anti-GD2 titers truly matter, they are surrogate endpoints for survival, can we increase those titers? And so are there any other adjuvants which could be used? So we were using quite quote-unquote old-fashioned adjuvants like KLH and saponins, a relatively untested adjuvant, which is glucan, and then the only adjuvant that has been approved in a cancer vaccine is GM-CSF. And our patients are well versed with receiving GM-CSF. So we decided to add this as another immune adjuvant. And I'll come to the current study. Another question is that, do the titers that patients make, do they stick around beyond the 1 year of vaccine, or do they fall? One drawback to our study was that after patients finished vaccine, at 1 year, we were not able to get a whole lot of samples because most of these patients went home and got their scans at home. And we had relatively few samples to study in patients beyond the 7th dose. So we really don't know for sure whether most patients maintain their titers. So we wanted to ask ourselves that, and just like there's a lot of talk about boosters in COVID vaccine, for example, we ask ourselves the question, should we give boosts to our patients with the assumption that titers will fall, although we don't know that for sure. And then we also wanted to study beta-glucan a bit more. So in the current trial, the first question is, what should we do with beta-glucan? And now we are going to treat all our patients with beta-glucan early after the first dose of vaccine, because we do have some inkling from the preliminary data on the prior study that this might be beneficial. Will GM-CSF enhance anti-GD2 titers? So we randomized our patients. Arm 1 will get the standard vaccine, and the Arm 2 will get the standard vaccine plus GM-CSF. Is there feasibility of revaccinating our patients? That is, patients who relapse. If patients who get vaccine, then they relapse again, should those patients be revaccinated? Because we know that even patients who relapse 2 or 3 or 4 times, there is still some mileage to be gained out of achieving remission and maintaining remission. And so we have a third arm in which patients who either are allergic to GM-CSF or have previously relapsed on vaccine or after vaccine can still be enrolled and studied. And then the other question I mentioned was, is the maintenance of titers important and can we achieve that? So we will be giving 4 boosters every 3 months in the second year, and then boosters every year, years 3, 4, and 5. Many questions and challenges still remain. The question that we get asked a lot is, what about patients in first remission? Should patients receive vaccine? If so, when and why? And this is a very, very difficult question to answer because current data indicate that patients who finish antibody, you go into transplant or you finish induction chemotherapy in remission, and you stay in remission after antibody. And at that point, if you start the clock, about 70% of patients will never relapse again. And so and some people would argue this number might be even higher. So in order to make a statement that a vaccine or any other maintenance therapy is going to benefit patients in this setting, a randomized study will very likely be needed. That is, half the patients will need vaccine, and the other half either nothing or something else. And to conduct such a study will require many institutions. And if I were to hazard a guess, we'd probably need about between 250 and 400 patients per arm. And that requires probably transatlantic cooperation. Now, even for our own data, where we feel that patients in greater than equal to second remission are benefiting from vaccine, even those data need to be reproduced in multiple centers. And again, this will need pharma involvement. And then we should not make the same mistakes as we made with antibody, which has been priced out of range for all our patients in all countries other than the Western world, America and Europe. Everywhere else, getting antibody is truly exorbitant and can bankrupt patients. So how can we make the vaccine available in less affording countries where this is a relatively cheap vaccine to produce compared to antibody? And this is a really important question, which is very near and dear to my heart. I'll end by thanking a lot of people, and too many to acknowledge, and I'll just leave time for questions at the end. So thanks for your attention.
Thank you so much, Dr. Modak. Lots of great information there. We're going to go to Dr. Sholler next, but if you can hold on, Dr. Modak, there are quite a lot of questions coming in, and we'll do a Q&A at the end. So over to Dr. Giselle Sholler.
Hi, everyone. Can you see my screen? My slides?
Yes, we can see your slides. You're ready to go.
Okay, great. Thank you so much for inviting me here to be with you and share some updates on our DFMO. I just wanted to introduce myself. I'm chair of the Beat Childhood Cancer Research Consortium, and this is the sites across the country and across Canada where that are participating in our clinical trials. We have now over 60 hospitals and research centers that participate in our work based on phase 1 and 2 clinical trials and our precision medicine and now immunotherapy clinical trials as well. Today, though, I'm just going to highlight focus on the DFMO, and our rationale for using DFMO is that, as Dr. Modak pointed out, many patients with high-risk neuroblastoma can get into remission, but maintaining that remission is what is challenging. Our goal is, can I move this? There we go, is really trying to target the cancer stem cells. Kind of the cancer stem cell theory is that our chemotherapy hits rapidly dividing cells. And as we hit the rapidly dividing cells, the cancer stem cells, which are more quiescent, are able to hide, and then those are the cells that cause relapse. Whereas if we can target the cells that have the cancer stem cell properties, that can lead to tumor shrinkage and regression and prevention of relapse. And when we look at DFMO targets a gene called an enzyme called ornithine decarboxylase, or ODC. It's an irreversible inhibitor of this, which downstream of this pathway is the Lin28-Let7 pathway. And this is a pathway that's very important in cancer stem cells in many different cancers. When Lin28 is overexpressed, the cells have more of a cancer stem cell property and can regenerate tumors. When we decrease Lin28 and increase Let7, the cells reverse, become more differentiated, and are not able to form tumors. Let7 is also important because it's a regulator of MYC-N, and when Let7 is suppressed, as is in most neuroblastoma, MYC-N is overexpressed. When we can increase Let7, we can also inhibit MYC-N, and we've shown that in our preclinical work, which I'm not going to go into today, but DFMO decreases Lin28, decreases MYC-N, and increases Let7. And so that's the rationale of using this medication as a preventative medicine in neuroblastoma. So where we first started using this after our phase 1 trials was at the end of upfront therapy. So as we all know here, children with high-risk neuroblastoma receive chemotherapy, then surgery, transplant, and radiation, then antibody and cisretinoic acid for 6 months. And then here, normally the treatment stops. We have added on DFMO for 2 years. DFMO is a pill that children take twice a day, every day, continuously for 2 years. The dose in this first trial was 750 milligrams per meter squared. We published this in multiple different papers. The most recent one was our historical control compared to our own sites. When we talked with the FDA, they asked us to look at 2 historical controls. One was comparing to AMBL0032 study by COG. So because we found that at the end of our first phase 2 clinical trial, 81 of our patients on that study had come directly from AMBL0032 onto our trial. And so when talking with the FDA, they asked us to do 2 comparisons. One was to receive the data from COG of the AMBL0032 study and do a direct comparison for patients that either got DFMO or the rest of the patients that did not get DFMO. That comparison has been done, but we are embargoed with COG, so we can't share that data until next year. But we did share that with the FDA. In addition, the FDA also asked us to do an internal control to do a historical review of all of the patients treated with neuroblastoma at Beat Childhood Cancer sites. So we looked at in the first phase 2, there was 20 hospitals that participated. So all of the hospitals did a historical control of all patients treated with high-risk neuroblastoma at their hospitals before DFMO, and then the patients treated at their hospitals that got DFMO. So this is the result. This was published in the International Journal of Cancer last year. And we can see that children at the same hospitals who did not get DFMO are in the red, and the ones that did get DFMO are in the blue. And we can see that the 5-year overall survival for those patients went from 66% of children not relapsing to 85%. And the overall survival was 82% versus 95. And this was statistically significant, as we can see by the p-value. So we were able to increase both event-free and overall survivals at our hospitals. And the physicians, taking care of kids at their own hospitals pre and post DFMO, all noticed a significant difference in outcome in our patients at our hospitals. Also wanted to give an update of the adverse events with DFMO. As you can see, this looks across all our DFMO studies. We have many different DFMO studies open right now. So 569 patients have been treated so far with DFMO, and we can see the breakdown. And this is a little bit hard to read, but we do see some grade 4 hematologic toxicities. Those are primarily at the higher dose of DFMO, which I'll talk about in a moment. And other than that, there's some effect on blood counts. Very few patients have actually, maybe about 4 patients have required transfusions. We have seen some increase in AST and ALT, but those were possibly related to DFMO and therefore reported, but there nothing clinically significant from those. And in terms of other than that, the hearing loss many patients already came on with high frequency hearing loss. The hearing loss with DFMO is a reversible hearing loss. And so it's something we monitor. When we see children have a decrease in hearing of 20 decibels, the DFMO first is monitored for a month to see if it is continuing to drop. If so, then we hold the DFMO, and it usually takes about 2 to 4 weeks for the hearing to reverse to whatever the baseline was for that patient. And then we can start the patient back at a lower dose because it is a dose-dependent hearing loss. But again, it is reversible. And so other than that, there's really very few grade 3 and 4 toxicities that we see with kids. And so based on the comparison of the AMBL0032 COG data, as well as the comparison with our own internal historical control, we were granted breakthrough therapy designation in April of last year from the FDA. And we are now working with the FDA to submit a full approval package. We did have a meeting last week, our pre-NDA meeting, which means pre-new drug application meeting with the FDA. And there is one additional analysis they would like us to do, which is review of all of the scans, central review of all of the scans independent from us. And then we are ready to submit for a drug application. The goal is by next spring to be able to submit and hopefully move DFMO, at least for evaluation as to whether or not this will be an approved medication. And so I just wanted to give an update. I showed the results of our first phase 2. After the results of the first phase 2, given that specifically the increase in overall survival by about 15%, the FDA agreed it was not ethical to have a randomized control population or placebo control population in that group of patients. And so they asked us to do a confirmatory phase 2. So this is where our current study is everyone is receiving DFMO still. And it similar to the first study, is primary objective is improvement in event-free survival, and then secondary overall survival. We have 4 arms on our current study. The first arm, which was the same 750 milligram per meter squared dose, has met in accrual, and now we're following those patients for follow-up. What we decided to do, because the drug is not being approved, to continue to have access to that medication. One question, has been brought up many times is this dose high enough? Is it, the right dose for kids? So we opened a second arm, stratum 1B, which is a higher dose, 2,500 milligrams per meter squared twice a day. And it's in this dose level that we do see some more hematologic effects, and some of these kids have required blood transfusions, and the lower dose did not occur. And so we are testing now a higher dose, and this is for patients who complete standard COG induction, consolidation, and maintenance. So this is different than the international patients who are in first complete remission following standard upfront therapy, different from COG. So that is the Europeans, Asians, South Africa, other patients are still receiving the standard dose, and this enrollment is still open. So these are most of the international patients that we see. We did look at, in this population also, 2 other stratum, which have met enrollment and are closed. Patients who are in first remission after refractory disease, and also patients who are in first or second or subsequent CR. So in, as Dr. Modak mentioned, patients who do relapse can get back into remission, and then maintaining that remission is critical. And I'll talk a little bit in a minute why we separated these 2 out, whereas in our first phase 2, these were grouped together. But biologically, we feel these are 2 very different groups of patients, and so separated them out in this trial to try and understand them a little bit better. But again, this single, just DFMO alone, has been closed. We do have a new study for those patients. That's the BCC015 study for patients who are relapsed refractory neuroblastoma, where they'll be receiving both DFMO and low-dose oral etoposide on trial. So this study opened just about 6 months ago. The reason that we are, the reason that we had separated, as I said in the last study, the OFID-14 study, the relapsed refractory patients came from our first phase 2. And these are the results of our first phase 2 DFMO for high-risk neuroblastoma in remission. Following relapsed refractory disease, we had them as one group. And we found that the 2-year EFS was 54% and overall survival 84%. And this, goes out at 2 year was 54%, 44% stayed in remission 5 years. So as Dr. Modak pointed out earlier, these patients who historically we thought were incurable after relapse or refractory treatment, by receiving additional therapy, by receiving a maintenance, whether it's DFMO or vaccine, can be cured, which is really encouraging to us. And then again, the overall survival of these patients, 84% at 2 years, 62% at 4 years. And this study was only powered to look at this group together. When we separated it out and looking at the relapsed versus refractory populations, we did see a big difference. We saw that the relapsed patients, are patients who responded well initially, got into remission, but then relapsed, actually had a worse outcome. Their 2-year event-free survival was 35%, 2 years, 80% overall survival. But the refractory group, who are the more challenging to get into remission initially, but if they continue to get therapy and eventually did get into remission, their overall survival is actually 70%, and 2-year overall event-free survival is 70%, and their 2-year overall survival 89%. So this was a very interesting biological difference that we're looking to understand, and so as you can see, the curves are very different, and so in this study we wanted to say, okay, 50% staying in remission is good, overall survival 84%, but we want to do better. And so how can we do better? Looking at going back to our phase 1 trial. In our phase 1 study, we used DFMO in combination with etoposide. Mechanistically, again, we're trying to increase LET7. As I showed earlier, DFMO suppresses LIN28 and increases LET7 in this pathway. Etoposide also, by inhibition of STAT3 phosphorylation, can also increase LET7 and suppress LIN28. So both working from different pathways can target the same molecule. This is some preclinical work that we showed many years ago, prior to our phase 1, that the combination of DFMO and etoposide in cell lines is more effective in 3 different neuroblastoma cell lines. And in our mouse models, we show that this was able to treat neuroblastoma with active disease. And so what we wanted to do was, if we combine the etoposide with the DFMO, can we do better for these patients with relapsed refractory disease? So on this study, each patient will receive etoposide at 50 milligrams per meter squared PO daily for the first 14 days of each 21-day cycle until 6 cycles have been completed. And the DFMO is also given a little bit higher dose, 1,000 milligrams per meter squared twice a day. And then this will be followed by an additional 630 days of DFMO alone. So seeing if that DFMO and etoposide combination targeting that pathway a little bit more aggressively at first for the first approximately 5 months will be even more helpful. This trial has 3 arms. We have subjects who have refractory in one arm. Subject arm 2 is patients who were previously relapsed and now show no active disease, so in CR2 or greater, after any remission after CR2. And then we also have a group of patients who are relapsed refractory with active disease. So this is more like our phase 1 study. This arm has 38 patients. We've actually enrolled over half of this arm already in less than 6 months. We do anticipate this arm to close within the next 6 months. That's been a very popular arm. So patients who have relapsed refractory still have active disease, but are looking for something that's a little bit more tolerable. That arm is enrolling quite quickly. And so that will help us really understand the differences between those 2 populations. We have some biology that we're trying to study on that study as well. And then finally, I wanted to highlight our upfront neuroblastoma study, where we are looking. One of the things the FDA asked us for was, while at the end of antibody therapy going forward, they felt it was unethical to randomize at that place because of the improved survival that we were seeing. They asked us to look, where could we do a randomized clinical trial with DFMO? Well, in looking at upfront treatment, historically, 14% of children actually relapse while they're receiving antibody and cisretinoic acid. So we don't know if we add DFMO earlier at the beginning of antibody in combination with antibody and cisretinoic acid, could we do better if we add DFMO at this point to prevent those relapses that are happening early? And so that is our current clinical trial. I'm not going to talk about the beginning part, but it's any patient that has received, patients can enroll on our upfront study at 2 places, either at induction or at the beginning of randomization. So even if you've received standard induction, transplant, and radiation, patients can still enroll at one of our sites on the randomized study and potentially receive DFMO during zintuximab and retinoic acid. So this study is a large, randomized studies require a lot of patients. So it's actually a 400 patient study, 200 per arm, to look and see if, and all patients continue and get DFMO for 2 years after. But does that adding that DFMO during antibody make a difference? We have about 100 patients enrolled so far. Again, it's going to be a long trial because we do need to enroll 400 patients. It's open at about 30 centers currently, and we are hoping to open it at more of our centers as time goes on. So that will help us to answer the randomized question, which I think is really important that we answer. And so just these are common international patient questions that we receive, and I just wanted to answer them and have this available. How do we get in touch and when do we get in touch is one of the questions that a lot of patients email and ask. So we ask that families make contact about 2 months prior. So while they're getting their antibody, wherever they are, prior to enrolling on study. And this is the email that will connect us with our group, and we can help get patients coordinated. We have a global health team at Living Children's that assists families with visas, any COVID regulations from all of the different countries that patients are coming from. They're aware of all of the different COVID regulations, including testing, and helps to coordinate. They help to coordinate that. They help to coordinate travel once they're in the United States. They'll pick up patients at the airport, bring them to the Ronald McDonald House, housing at the Ronald McDonald House, travel to appointments, arrange translators, etc. So this global health team has been really wonderful to have over the last year. This is new for our program and has been very helpful. We'll have a coordination of care video call to be scheduled with you and your clinical team about usually a month prior to coming to our center, so that we can provide good continuity of care and create a team supporting your child, your home team and our team together taking care, because the kids will be going back and forth. DFMO is provided free of charge on study. There is no charge for the DFMO. And then on the 014, the end of upfront therapy, versus 015, the relapse refractory, there is a little bit of difference. 014 study does require 6 visits over 2 years. At study entry, at 3 months, at 6 months, at 1 year, at a year and a half, and the end of study. And then the 015 is 9 visits because it's every 3 months. The in-between visits are, you can be seen at home with your home team, and we'll communicate and coordinate with them. How much does it cost is the other question. So if scans and audiograms can be arranged in the home country, then each visit costs about $2,000 per trip. And if we have to do scans and audiogram at our site, then it costs about $15,000 per trip, less if your child does not need anesthesia. And each patients are only required to pay for their trips one at a time. You don't need to pay for the entire study up front, just for each trip prior to coming. So those are the main questions that I get a lot from families, and I just wanted to kind of answer them all in one slide, and then you can have that for further information. Again, we are, I want to thank everyone that's participated in our research, especially all the patients and families, and the Beat Childhood Cancer Foundation that's supported the majority of the DFMO work, as well as other foundations listed here. And I just want to thank everyone. Everyone knows Lily May, I think, one of our first families from Europe to come and participate in the DFMO trial. And we are hopeful that next year, that we can move this forward with the FDA. And there is a company, Norgine, that is looking to bring this forward in Europe as well, based on our package that we're submitting to the FDA to submit that package to the EMA. So I'm happy to take questions, and I'll stop here. Thank you.
That was great. Dr. Sholler, thank you so much. We're going to go now to a pre-recorded session, but we'll be back to you for questions. There are quite a lot coming in. So now we're going to go to Dr. Moreno for a pre-recorded presentation on the options of relapsed neuroblastoma for after achieving a response or a stabilization of disease.
Hello, good morning, good afternoon. I'm Dr. Lucas Moreno. I'm from Barcelona, Valdebrán. I'm a pediatric oncologist, and I'm very, very grateful for the organizers for inviting me to give this talk. Today, we're going to briefly cover the options that we have with a patient that has a relapsed neuroblastoma after we achieve a response or stabilization of their disease. And I hope to briefly cover this topic. Here you can see my conflict of interest statement. And we will briefly cover the treatment pathway for relapsed neuroblastoma and what do we do after achieving a response or disease stabilization. Here, first, I wanted to show you that some of us in the European group in COPAN, we have been trying to develop an overall strategy for relapsed neuroblastoma for children with high-risk neuroblastoma that relapses, and of kind of an algorithm of what to do at the different time points of the treatment. What do we really mean here? I'm sure you've already heard that at the time of the first relapse, we have got some options, most based on chemotherapy. So the chemotherapy alone, chemotherapy with anti-GD2, chemotherapy with bevacizumab in the Beacon trial, the RIST regimen. But after starting on the chemotherapy, we always do sets of scans after 2 cycles, 4 cycles, 6 cycles of treatment. We do MRI scans, MIBG scans, the bone marrows. And what do we measure here? Well, there are internationally agreed criteria. They're called INRC, and they are used to assess if the tumor shrinks so that we all use the same criteria. So here we know we have got one category is a complete response. So the tumor has completely disappeared. A partial response, it has reduced in size or reduced the number of lesions. There's a stable disease, which the tumor basically remains the same, or there's progressive disease where the tumor either has increased in size or in the number of lesions. And we do this because we think that's a way to measure whether the treatment is working or not. And we think that the better the response, the better the outcome of the patients. But after, after giving this first treatment, of course, if there is progression, if there is the tumor is growing, we know that this treatment is not working and we need to move forward to another treatment. And other colleagues like Dr. Pablo Berlanga or John Maris or others might have touched on treatment options and other clinical trials. But today we're going to focus on what do we do if there is a response or the disease is stable. We know that treatment's working, but we want to make this treatment work for longer. So do we continue with the same treatment or do we rather change treatment as we do the frontline regimen where we have different phases of treatment of the patient from one phase to the other? And I wanted to point out an aspect when understanding the data for options at consolidation and maintenance that is particularly difficult to compare the different treatments because there hasn't been a big randomized study where we have all the options together and the patients go to one or the other arm and we compare them head to head. Every trial that has been done is a relatively small trial with a heterogeneous population and they're always difficult to compare. But also there's an extra bias that because we're giving treatments at the end of the treatment, the patients with less aggressive disease are selected because those that progress very rapidly are already out of this pathway. And every treatment looks better when you give it in consolidation or maintenance. So it's harder to understand. And this is just an example to illustrate this from the Beacon trial, but this applies to many treatments and possibly Daniel Morgenstern has also touched on this point. So on the left, we have got the survival. These are the survival curves that we use to see how the patients remain without a progression or relapse on a trial in the Beacon trial. So when all the patients at the time of entering the study, the trial, there were 160 patients. And if we look 1 year later, after entering on the study, there are less than half of them are free of relapse. So the majority have already relapsed. However, if we measure this survival for patients that have finished the study, from the time that they finish the study after 6 months of treatment, well, there is only 45 patients. There's not 160 because many of them haven't completed treatment or have progressed already. So for these 45 patients, if we look at them at 1 year, 3/4 of them, more than 75 for them, are free from relapse. So it does look that these patients are doing a lot better, but it's not because they got a very good treatment. It's just because they're selected and they're in a different time of treatment. Couple of remarks. There are different phenotypes. Not all the relapsed neuroblastomas behave the same, and there are some of them that behave very aggressively and grow very rapidly, and this is often associated with MECAN-amplified neuroblastoma. And there is a more chronic or indolent course in children that are either older or harbor ATRX mutations in the ATRX gene. And also at this point where we are after a response or stabilization, there will be often different options, different opinions, and the options may change depending on the type of the situation of the patient, the status of the disease, or which trials or drugs are available. I've divided the options into consolidation into options that are more consolidated, more established, and these options are available in the majority of the centers, in the majority of the countries, particularly focusing in Europe. And the first of them is that if the patient hasn't received anti-GD2 therapy in the first line, then a good way of consolidating them in second line in relapse is to give anti-GD2 therapy. There's also the option of considering local therapy, just surgery of an isolated lesion or radiotherapy of an isolated lesion once they are responding. It cannot be done if you have got many lesions, but there are some circumstances where this might be of help. There is a group of patients where the disease comes back in the CNS, in the central nervous system, brain. This is a very specific group which we won't extend much in today, but there's an agreed standard treatment to do surgery to remove the lesions that are in the brain, if this is possible, and then followed by chemotherapy and craniospinal radiotherapy. There's the option of MIBG therapy, and I'm sure Professor Matthey has already covered this very, very nicely. But then there's also the option of continuing with the same chemotherapy that we have been giving before. And this is just another valid option. And here I wanted to mention, for example, a study that the French group did with patients receiving temozolomide and temozolomide combinations. So for patients that receive long-term temozolomide-based regimens, so temozolomide and other combinations, for those that receive more than 6 months of chemotherapy without a progression, so if disease doesn't come back within the first 6 months, there's still a group of patients that benefit from continuing temozolomide treatment for a very long time, even beyond 12 months. And this is still a reasonable option. And the same applies for chemotherapy with chemotherapy with bevacizumab. They can be given beyond 6 months. For longer. I wanted to mention also that there are emerging options for consolidation. These are less widely available, but also worth mentioning and considering. So the first of them is to consider switching to a targeted therapy regimen. So particularly for those that still have some disease, although it's responding or stable, we may have done a molecular profile, a biopsy and a molecular profile at the time of relapse, and we find that after 2 months or a few months, we find a new aberration that we didn't know about it. For example, sometimes we find ALK aberrations. So it may be a good option for consolidating a patient's relapsed neuroblastoma is if there is an ALK aberration, give an ALK inhibitor, for example. There's the lorlatinib NANT trial that is open in Europe, and also the CRISP trial that is open in several centers in Europe. that have got ALK inhibitor treatment for these patients. There are other targeted therapy combinations, and I won't go into details because Pablo Berlanga will have covered them, but there's the eSMART trial with many arms, several of them that are worth for MECAN amplified tumors. There's an Aurora kinase NANT trial that is also open in Europe. Another option is not just giving conventional MIBG therapy, but a trial with MIBG therapy. And for example, in London and Southampton, there's a Bivalent trial open with MIBG therapy, with nivolumab and with dinutuximab beta. And there's also a trial with naxitamab, which is another a humanized anti-GD2 antibody that is open and available for patients with residual or responding disease with some conditions, but it's also open in Europe, and it's another option. Yet another option in the emerging field is the haploidentical transplant. This is a transplant that is not the autologous transplant that we do in neuroblastoma, that is from the own patient. And haploidentical transplant is a transplant where the blood progenitors, the stem cells, are collected from one of your parents, from your mom or your dad, where we know that they're only half compatible with one patient. And we do this because the idea is that the transplant will have an anti-neuroblastoma effect. So this is a very common option in Germany. It's well established there, but is relatively rare and not often done outside Germany. They have reported results of a package of treatment where you give chemotherapy first, then MIBG therapy, then haploidentical transplant, and then anti-GD2 therapy for a longer regimen with some promising results, particularly for patients that enter this study with a complete or partial response. And then there are some other options that are also used for at the end of treatment. One could even say as a maintenance. So after we have finished all these previous options, you will have just in this session heard Dr. Sholler speaking about DFMO, Dr. Modak talking about the GD2/GD3 vaccine. So these are valid options that are emerging, not so. They're more difficult to accept within Europe up till now, and then specifically for CNS relapses, then there's also the option of the omburtamab trial that it's open in Europe as well, specific for CNS relapses. So I won't give more details about this because we've just heard about them, but I wanted to conclude with a couple of messages. The first is that definitely achieving a response or a disease stabilization after a relapse is a positive milestone, is a good news. So we need to, even if there is a difficult decision to take, it's good news, and there's some more hope that the disease will remain under control for a longer time. It is important to consider all available options for each patient, and there are many variables here. In the number of available options, the type of relapse, not all relapses are the same, the type of response to the first treatment that we've given for the relapse, the molecular profile of the patient, and then the trials or treatment options that are available at a particular center or country, and the evidence for each available for each of them to help us taking the decision. However, it is a point where taking decisions is particularly difficult, and we've heard many times parents saying that it's very burdensome because they always want to trust their local clinician, but they wonder, are there other options, and is our local clinician consulting with everyone that know all the treatment options? Is it worth moving and looking for options in other centers, in other countries? And this is an area of work where Helen Pearson, that is an advanced nurse practitioner from the UK, is doing the REDMAP study, particularly to try to understand and help this decision taking, because it often seems that a lot falls in the patients and the parents to take the decisions. but definitely the decisions are best taken jointly by informed parents, well-informed parents, with local clinicians and also reference clinicians that are available in all the networks, considering the patient's specific situation and also the patient's preferences. So having all together will help us to take the best decision for the patients. So I wanted to conclude here with this brief overview of what do we do and how do we manage when we achieve a response or disease stabilization, covering the different treatment options. And I'll finish here thanking very much the organizers for inviting me, and particularly Solving Kids Cancer, which I work with very closely. So thank you very much. I'll be happy to take any questions with a delayed response, but I'll be happy to take questions later. Thank you very much.
Thank you to Dr. Moreno for that presentation. And as he said at the end there, he is willing to take any questions. So if not live, but with a delay. So if anyone wants to do that, we can do that. Okay, so now we're going to go to the Q&A session, and we'll invite Dr. Sholler and Dr. Modak back. We got a huge amount of questions. You guys probably noticed, almost 40 questions. So I'm going to take a stab at just kind of like putting similar questions together. And I'll just kind of go back and forth between questions for each of you. So I'll start up with Dr. Modak. A couple questions about whether patients that see a good response to antibody, whether they're more likely to get a good response with vaccine, if you've seen anything along those lines in your data.
I put this slide up. There's not enough information to say, but I don't think for overall survival it matters whether you received antibody before or not. I think to really definitively answer this, I think we'll probably have to do a trial where we combine antibody followed by vaccine.
Right.
Our philosophy for second remission is that we try to pull out all the stops. So if there is evidence that treatment is effective and non-toxic, we would probably try it.
Sounds good. One more group of questions. We got a lot of questions about gut health and whether you, if you have any insights about that. If you analyze the bacteria, how good flu can.
We do have a very, very robust program looking at the microbiome, and we've collected close to 200 patient samples. I'm waiting for our team to analyze it, but I think once we have that, we do have some preliminary data that gut microbiome does matter, but the specific question we are asking is whether it matters for immune response. We all know that after chemotherapy and even after antibiotic, even after a single dose of antibiotic, your gut flora can be completely changed. And in the beginning of chemotherapy or beginning of neuroblastoma treatment, the gut is really kind of ravaged by all that. But towards the end, it starts bouncing back. Now, whether it bounces back in the right way or the wrong way, these are all very provocative questions which we need to look at going forward. There's a lot going on in the adult world, including the immunotherapy world. And we do have samples collected, so I think we might be able to look at this question in some detail.
Sounds good. Dr. Sholler, there was a couple questions for you about whether candidates can enroll in DFMO if they have minimal residual disease. And I don't know if you had any comments on that.
So yeah, it depends on which study they're going to go on. If it's truly active disease, then they would be eligible for the 015 Arm 3. We do look at patients at the end of upfront therapy. If there is still an MIBG positive area, we will do a PET scan to evaluate if that tumor is still active. If the PET is negative, we consider that they have no active disease, that it's likely that the MIBG is differentiated or mature, and then they can enroll on the standard study at the end. Just because there's maybe some still residual MIBG avidity, that doesn't exclude them necessarily. Some patients will have a biopsy to make sure that it's not active disease. And if that shows ganglioneroma or differentiated, then they're eligible, or we can either do that or a PET scan.
Okay. So in both cases, with both of your trials, it sounds like people should reach out to you and really look into that in their individual case.
Yes.
So both of you guys got questions about availability in Europe and beyond. So I don't know if you each want to address that one. Lots of interest from people tuning in Europe and in other countries. Can either of you want to talk through your timing on that?
Sure. Yeah, we are working with Dr. Thorsten Simon in Germany to open our clinical trials there, as well as with a physician in Greece. So we are looking at opening the clinical trials, but in addition, we are moving forward with both the FDA and the EMA in moving the DFMO forward in both here at approval and the Europe as an approval.
Regarding the vaccine, Y-mAbs, the company does have the rights to the vaccine, and they have started talking to a lot of people about running a trial in the phase 2 setting, including people from Europe and in the UK. But since they are driving that, I can't directly comment on that trial yet. In order for us to get the vaccine as a single institution to multiple centers is not really feasible. So we do need the pharma buy-in to make that happen.
Okay. That sounds great. Sounds promising, though, for folks elsewhere.
Yeah.
So let's see, one more. Let's go back to vaccine. Lots of questions, Dr. Modak, about whether patients who have been on an earlier vaccine trial, if their child unfortunately relapses, whether they can come into the new trial, either in compassionate use or in some other way to get advantage of that new combination with GM-CSF and then also boosters.
The new trial does allow patients who relapsed before to go on to Arm 3, which is a non-randomized trial, but does include the boosters. Because the GM-CSF is completely uncharted territory yet, I think it would not be feasible to put patients on the randomized trial, a randomized arm of it, the two randomized arms. But I think the general philosophy that patients who relapse, or even if relapse again, can get back into remission, especially if they don't have high burden disease. In my experience, that's been an even bigger obstacle to surmount than actually maintaining the remission. And there's plenty of evidence now that disease can either respond or, even as Giselle was mentioning, become mature over time. So I think an effort should be made to get patients back into remission, and either that could be done via trial or it could be done via standard treatment. And in the modern era, chemoimmunotherapy has become so widely used, either with dinutuximab, naxitamab, or dinutuximab beta, that an increasing number of patients are responding even in second, third, and fourth relapses. So I think that effort is really important. How to keep them in remission is a bigger question, and hopefully there'll be vaccine, antibody, DFMO, one of those things, or even newer agents could come into that realm.
That sounds great. Going back to you, Dr. Sholler, let's see. I know you touched on this in your presentation, but do you want to talk a little bit more about higher dose DFMO? Since there's been other studies looking at the levels of DFMO?
Yeah, sure. One of the reasons we started with the higher dose DFMO was that we did see in our first study a few patients relapse in the CNS. CNS is a sanctuary site that is a little bit harder to get into. And DFMO does cross the blood-brain barrier, but at about 25%. And so we wanted to see if we increase the dose, we call this our CNS dose, that this dose should be able to get into the CNS at adequate levels. And that was a main reason for increasing the dose. So we are using that dose in brain tumor patients. We are treating patients with ETMR. We have a medulloblastoma study is open as well for kids at the end of upfront treatment with high-risk medulloblastoma. And that in those studies, we are using this higher dose. We have a few patients now that have relapsed in the CNS who then received omburtamab, radiation, and then high dose DFMO after to try and maintain that remission. And so It'll be interesting to see, head-to-head in the same trial comparison of the 2 doses, and if we're able to inhibit additional relapses. But that was the primary reason for us in terms of the higher dose, was really to be able to reach the CNS.
Interesting. Another question for you, Dr. Sholler, about whether you're looking at doing a randomization of patients after first remission so that the COG and SIPN groups have that data to incorporate into their protocols?
Yeah, so the randomization we chose to do was a little bit earlier, as I mentioned. We're doing the randomization. We agree that a randomized trial is really important, but our randomization is during antibody. So antibody and retinoic acid alone versus antibody retinoic acid plus DFMO. And that is enrolling well, but it is going to take a while. So any sites that would like to participate, we'd love to have more hospitals joining us in that.
That sounds good. Same question for you as I had for Dr. Modak earlier. What do you have to say to parents who have a second relapse? Are they able to do DFMO again?
Yes. So patients, and we have had a few who have come on with receiving the higher dose. So if they relapse on the standard dose, and we also do have a expanded access protocol where we can, so for patients with ALK mutations, we've been able to put patients with DFMO and an ALK inhibitor together for longer term care, or other kind of combination therapies that we think are important for a multiply relapsed patient that has a target that we should be targeting as well. So there are options, and they can receive DFMO. We usually do it in a little bit of a different way than they had it the first time.
So is that part of the trial, or is that kind of compassionate use, or kind of a combination depending on?
We do have an expanded access protocol for patients that don't qualify for one of our clinical trials. Mm-hmm.
All right, great. I think I'll just probably end too. This has always been a big question for patients trying to decide between the two, because obviously these are two very different approaches to maintenance. Any advice from either one of you on how parents make that decision? I don't know who wants to go first now.
I can have a stab at that. I think whenever I consent patients in first remission, I always say that we really don't have any evidence that a vaccine will push because at the end of antibody, as COG and so on, and even in our long term, even if you look at long term, the outcome seems to be improving, right? So, say if you want to do something in that arena, I think we need the randomized trial. So, for second remission, we have a lot more data, and there have a little more confidence that the vaccine is doing something. But automatically for patients in first remission, I think they should consider the pros and cons carefully. And it's relatively easier for patients here to make a call because the vaccine is quite a safe agent. We've tested its toxicity forever. But whether it's beneficial or not, I don't know. And so this is a trial. It should be considered as a trial, not as any evidence, clear-cut evidence-based, because in that case, it would be approved by now. So there's some ways to go.
Yeah.
I would agree. And that's generally what I tell families too, because many ask which one should we do? And I say they're both clinical trials. They're both asking good scientific questions. And I don't know which one is better, DFMO or vaccine. I think they're both good research studies. And it's really important for the families to, talk to me, talk to Dr. Modak, and see which, as he said, weigh the pros and cons for them, for their families, and make a decision. I would love, Dr. Modak, at one point to see if we can do a trial combining the two, because I think that you would.
Things have changed on the regulatory front, right?
Because now it's challenging on the regulatory front.
Which is not in our hands also in terms of how to develop the antibody. But also I should add the third option is to not do either of them.
Yeah, absolutely. And that is when, that is the standard of care, is to not do anything further post antibody.
And that is remission patients, I would pull out all the stops and, definitely in the modern era, because the salvage therapy has become so much better. And both Giselle and our teams have shown that long-term, I hesitate to use the word cure, but in reality, cure and long-term survival is really possible.
Possible now.
And, sometimes even probable, like for low burden relapses, you may not even have to deal with very toxic salvage treatment. So I think that's the take-home message from me, is that we really should make an effort keeping that philosophy in mind for second
Yeah,
remission.
That sounds good. Thank you both for your thoughtful answers on that. A couple more. I've been told that we have a little bit more time, so I'm going to read a couple more that came in. Dr. Modak, what happens if you complete the vaccine and their child is not developing titers? What is next?
Yeah, so I get asked this question a lot, but this is not a clear certified test. It's a research test. We're trying to move it out of our lab into a clear certified lab. So what that means is that if this test is developed, say like a urine catecholamine test, right? If a titer test of that sort exists or is developed, then those data can be shared with the patient and the patient can get the data in real time. In reality, what happens is we pool the data, the samples, and we run those samples like every 3 or 6 months. And that at that time, it's not really relevant to the patient. So that's one point. The second point is that many of our no titer patients also did quite well. So I had mentioned in a slide that this is only one way of measuring the immune response. And it is an easy way rather than the ideal way. Right? The ideal way would be you'd find some test to measure T and B cells. B cells are being measured with the titer, but T cell function is still a black box. So I think the titer, we have many patients who are long-term survivors with not measurable titers. And then patients who then get re-challenged, a general experience has been that the titers go up quite a lot with re-challenging. So the low-level titers might exist, which we're just not finding the right way to measure them.
Does re-challenging mean to repeat?
Relapses and then goes back onto vaccine. Often we see the titers go up quite a lot. So that's, I think, reassuring to the principle of using the vaccine.
And that's the reason why you kind of looking at the idea of boosters also, just to kind of extend.
Yeah, but whether, as I said before, we don't really have that many patient samples beyond the first year because patients get vaccine, then they go home, do the scans, and then getting a sample back has been difficult. But now, because of the second group of patients, we did make a concerted effort to get samples. The paper we published, I think we had only about 10 or 15 patients with samples beyond the first year. So we need much more data to say that boosters are really needed. But that's what the trial's asking. The positive side is that it's a relatively safe drug. So I think adding boosters will not significantly increase the risk of toxicity.
All right, that sounds good. Looking here to see if I see any other questions. A few questions for you, Dr. Sholler, or actually for both of you, about MYC amplification and whether there is data now, Dr. Sholler, about the DFMO does seem to work better on those patients. It's something that parents talk a lot about when they're trying to make a decision. Yeah.
So what we were able to show, in our first study, when we separated out the MYC amplified patients versus not MYC amplified, and while historically, in our historical data, the MYC amplified patients have a higher risk of relapse than the non-MYC amplified, and yet for the patients that received DFMO, both groups increased to that kind of 85% staying in remission. And what we've shown in the lab is that the DFMO suppresses MYC-N. So we anticipated that it may be more helpful in that group of patients. While it's helpful in both group of patients, it is more helpful in the MYC-N amplified in that they start off at a lower event-free survival rate, and it brings them equal to the not MYC-N amplified. And so there is, it kind of takes away MYC-N as a risk factor in our patient population that we studied.
I do want to comment on that. I think in the modern era, MYC-N amplification is not a poor risk factor at all. In my experience, our experience, and including the COG, I think will end up saying that, is that in the modern era of high-dose chemotherapy, MYC-N is not going to be a poor prognostic marker. And I think MYC-N, there are two groups of patients. One group of patients respond exquisitely to chemotherapy. In those patients, actually, I would hazard a guess that 10 years from now, we'll be saying that's the best group in neuroblastoma. Of course, it's a provocative kind of opinion. In the era before high-dose chemotherapy, certainly MICAN was really bad, but it's not a independent prognostic marker for overall survival anymore, including the COG studies. So having said that, the second group of patients in MICAN, which is a very small minority, thankfully, is that those patients who don't respond to chemotherapy or relapse very early within the first 6 months after achieving remission. That's a group of patients we are failing miserably. And they have such aggressive disease that to get a handle on those patients is extremely difficult and invariably lethal. There's that to be big. It's a big challenge for us and for the people to come, investigators to come beyond. Now, we all focus on MICAN amplification, but there's MICAN, even the normal amounts of MICAN also playing a role in cancer in the development of neuroblastoma. So there's certainly a role for MICAN suppression, which might help both patients with MICAN amplified disease and MICAN non-amplified disease. So in that setting, disease agents like DFMO and other agents that are being looked at for MICAN suppression certainly should be investigated.
All right. Well, thank you to both of you for your great presentations and for all these questions too. And thanks to everyone watching and for the great questions. Sorry, apologies to people that we didn't get to your questions. There were just way too many. But we are moving on to the next session, I think, is at 4:35. Oh, hold on.
See you.
The next session is at Greenwich Mean Time, 4:35, and it's on the role of high-dose chemotherapy in neuroblastoma. And remember, if you missed this session or you have friends you think might want to watch this session, all of the presentations are available on demand. And I've been told that the sessions from yesterday are now loaded. So go back and take a look at those and enjoy the rest of your day. Thank you.